Welcome to Diabetes mellitus. We're going to be focusing on diabetes mellitus type 2 today, and the slides you'll see throughout are many from the AACE guidelines and algorithm. As a sidebar, there are actually thought to be three types of diabetes now. Type 1, which we used to call juvenile onset. Type 2, which we used to call adult onset, but of course now occurs in obese children, and 1.5, which is latent autoimmune disease in adulthood. And I'm not going to belabor this, but we basically treat 1.5s as a 1, which means, of course, they need insulin. I want to just remember or refresh your memory that the medications we're going to talk about are only part of the picture. There are lots of pieces to the management of diabetes. I want to point out two important things, though, is that we have an optimal A1C of less than 6.5 according to the ADA and AACE, and however, there are going to be some adjustments to that depending on the person's comorbidity and age, and that the initial choices are affected by the A1C, which we're going to talk about in a minute. I do want to give a nod to pre-diabetes, overweight. This is in type 2, the pre-diabetic state with obesity, that there are several medications that are used in the case of lifestyle not being effective. And just a quick reminder that there are some things that you'll see used for other things, like we talked about in the neuro lecture, like such as topiramate, and later you'll see bupropion in the mental health lectures. Let's start with a case. We've got George. He's 52. He's got a complaint of fatigue. About 4 weeks, he thinks. He's lost some weight over the past 2 weeks, and he didn't even try. He was quite glad about it. He's been urinating 2 or 3 times a night and a lot during the day, and this is a problem because he's a trucker. He's very thirsty all the time. He doesn't have any other symptoms such as eye issues, cardiovascular, neuro or GI symptoms. I should have added neuro as well. His findings on a physical exam are that he's obese, otherwise within normal limits in terms of blood pressure, etc. And his finger stick glucose today is 235. That's a random, and we kind of wondered. So the algorithm says we've got to correlate with A1C, but we don't have an A1C machine in our office. Some do, by the way. And we can't get that instantly. So we might want to be able to calculate what the correlation is. And so we go to this conversion calculator, and some of this is chopped up, but again, the term EAG means estimated average glucose. So say we did figure out that his average glucose was the 235, and we're just going to poke that in and see what we get for an estimated A1C, and that is 9.8. And down below there's also a nice little table that correlates and tells you kind of where things are in terms of estimated A1C. I'll move the screen over so you can see what I'm talking about. The A1C on the left column, and then in the middle, the blood sugar in the middle. So if we came up with an A1C of 9.8, and that's our estimate. Again, we're not quite there yet. We may do some things before. We clearly see that he does not meet criteria for an A1C under 7.5. We can pretty much guarantee that based on what we're seeing today. In that case, we would go with monotherapy, and usually metformin is the first choice. Not only is it the cheapest and oldest drug, but it definitely helps, especially the obese patient with insulin resistance. A1C greater than 7.5, we use dual therapy. If that doesn't work, we move on to triple therapy. And again, these are all these different types of medications in addition to metformin, as long as it's not contraindicated and they can tolerate it. Triple therapy, again, and we see this a lot, and we'll explain in a minute why that works very well. A1C greater than 9, in his case, we probably are looking at that. And is he symptomatic? Yes, he is. He's got frequency of urination and and he's got a lot of thirst. So we've got the 2 polys. He doesn't yet have visual changes or neuropathic pain or cardiovascular changes that we know of, But we all know that diabetes is basically cardiovascular disease, and we are concerned about that in terms of target organ damage. So what now? Well, a couple of decision points, and again, in the best of worlds, we would have an A1C in our hands, and if we did and it was 9.8, we would clearly start him on the algorithm to the right, which is insulin plus other agents. And in his case, because of obesity, he's probably going to go on the metformin plus some insulin, and we start with basal, and we'll talk about that in a minute. And that is why. Some of you may wonder, what about DKA? Is he heading towards DKA? If his average sugar is 235 and he may bump over 250, criteria for entry into looking at DKA, we do wonder. So let's take a look. So just as a refresher, DKA is sugars over 250, but they have to have the criteria for the acidosis. I've got to say that many diabetic patients type 2 avoid DKA, despite the fact that I can see their sugars on entry of 400, 500. It's amazing. And they do not go into a ketoacidotic state or even the HHA state. However, if their sugar was that high when I saw them, I will send them to hospital for evaluation. But this is pretty unusual. It's more likely with your type 1s or 1.5s. So before we get into an actual plan for George, let's take a look at this table, which this slide, in addition to the algorithm slide earlier that directed us in terms of treatment by A1C or entry A1C, this is a great study tool giving you the profiles of the various anti-diabetic medications. You'll see here that our drug of choice that we start with, one of them, at least the metformin, has some good things in terms of green, so slight weight loss, but we do have to be careful if the renal clearance is not good. Now we're going to be checking George's labs, of course, but we're going to hope that his GFR is greater than 30 at this point. Later in his course of diabetes, of course, that will deteriorate if treatment is not maintained and his A1C is not kept low. I will make a note that, of course, insulin causes hypoglycemia. You know, I like to say to people it's a murder weapon, which is really awful to say, but that is because it can cause life-threatening hypoglycemia if not taken correctly. So we're really careful about administering it and instructing the patient. But there's also another class of drug, the sulfonylureas, that cause hypoglycemia, and therefore we never combine these two. So again, we want additive effects, but we don't want additive bad effects with our drugs. And this is a great slide too that helps you understand why we can add so many agents together, because these are what this author calls the ominous octet, the different things that cause hyperglycemia. And they include, of course, the pancreas not putting out enough insulin, the decreased incretin effect, decreased glucose uptake, increased glucose reabsorption in the kidney, etc., etc. So in all these places, it's multifactorial why these folks get hyperglycemic. And what we try to do is tackle each one of these. And of course, what's not included on this slide in terms of drugs, which are in the starbursts, is insulin, because insulin is replacing this. And that will always work. Although, of course, with our type 2s, there's quite a bit of insulin resistance, so that still has to be dealt with. And there's where the metformin can come in. Here's a little glossary to go with the slide prior. Of course, metformin we talked about in terms of its ability to decrease the insulin resistance, but it also decreases hepatic glucose production and decreases intestinal absorption of glucose. So it increases peripheral glucose uptake. So we really like this drug for our type 2s because they have such a high level of resistance. It's a nice drug too in that it does not cause hypoglycemia. We even give this drug for other reasons, such as polycystic ovary syndrome, to people who are not even diabetic but might have the metabolic syndrome going on, and it does not give them the hypoglycemia. Of course, it makes sense because of its work in the intestine and liver that people get diarrhea with this drug. The longer acting version, which is also cheap and on most of the $4 or $5 lists, is quite effective and causes less GI upset. So that's a little tip. New kids on the block, in addition to kind of the standard drugs that have been around for a while, particularly the sulfonylureas such as glipizide, glyburide, and all the others. There's so many of them. You're going to be talking about them on your discussion board. But the Siglet is something I wanted to kind of introduce you to. It is a few years old on the market now, still expensive and still branded. But this causes more glucose to be excreted and not reabsorbed in the kidney. And of course, think of the consequence of a very sugary urine sitting static in the urine in the bladder and the potential for infection. Your homework is going to be to go on the discussion board and to sell your drug in these drug classes. And I will let you unfold that out there in terms of the pros and cons of each of these drugs and how they might work to help a patient or hurt them. Now, I did want to call your attention to this particular slide. And so this slide is helping us understand why sometimes we will adjust the A1C goal a little bit upward because we find that that the patient may not be able to tolerate the tight control. So we tend to be more stringent in our control if we have low risk hypoglycemia, they're newly diagnosed, we have a long life expectancy, etc., etc. Over here, we're less stringent. We get an elder who might have a long-standing disease with important comorbidities. And of course, it's kind of a catch-22. We want to prevent these things from happening, like vascular complications. But at the same time, we want to be realistic in terms of, again, pretty much about life expectancy. Now, this one I do take some argument with. As the resources and support systems, they say here that if they're limited, you could loosen up the controls or the goal. And I say, you know, keep it as strong as you can and get them the resources. Of course, there's always insulin, and you're going to be working with that in your homework as well. There are several kinds of insulins. Please know the onset, peak, and duration of all. That is Nursing 101, but you need to repeat that knowledge. The algorithm for starting insulin, you're going to be looking at that in your dosing homework, but we want to take a look at their total daily dose, and at the beginning, when the A1Cs are pretty low, again, we keep that total daily dose fairly low or modest, and then otherwise we go pretty high. Adding mealtime control is very important if they're not at goal. And also our type 1.5s, we will almost always add a prandial insulin. And you're going to get into that in your homework and in the tutorial. This is just a reminder of the different mechanisms or the different onset, duration, and peak of the different insulins. And it's important to just note that these intermediate acting insulins, which are kind of old-fashioned, if you will, like NPH, actually are quite effective, but just have to be taken twice a day so that you can get an effect. I have some patients who do great with those. And of course, the mixtures, which have a little bit of the fast and slow acting. This is just another reminder slide. So think about these cases where you might have the best, what might be the best insulin regimen to go with them. And just quick and dirty on this, again, the LADA is probably going to need basal plus prandial. The 65-year-old, we're probably going to just keep on basal. And then with the cost-effective, we're probably going to go NPH because you can buy that over the counter, behind the counter, for a modest amount. Your homework on the insulin calculation you will see on the blackboard.